All right, let's talk about being a pharmacology code breaker. We are diving into one of the most high-stakes, absolutely critical topics you'll face on the NCLEX and, in your entire career, medication reversals. You ready? Let's get into it. Okay, I want you to put yourself right in this situation. You walk into your patient's room and this is what you see. They're just completely unresponsive, not moving. You see the IV dripping into their arm, and immediately your heart just starts hammering in your chest. You know something is seriously wrong here. So you check their breathing, and wow, it's slow, dangerously slow. We're talking 8 breaths a minute. You do a sternal rub, you shout their name, nothing. They are completely out. This is literally a code blue just waiting to happen. Your mind is just racing, right? You've only got seconds to act here. What are you thinking? What's the right medication, the right antidote that's going to pull them back from the brink? What are you grabbing first? And look, that whole scenario, that's not just for show. That is a real thing that can happen on the floor. And you better believe it's a huge theme on the NCLEX. Knowing these reversal agents, it's not just about getting a question right on a test. It's about being ready to literally save someone's life. Let's be absolutely crystal clear here. Having this info locked down cold, it can be the one thing that stands between your patient recovering and a totally catastrophic outcome. The people who write the NCLEX know this, and I promise you, they are going to test you on it. So think of this as us building your emergency antidote toolkit, okay? We're going to focus on the top 3, the most critical, most tested reversal pairs that you just have to know. No excuses, inside and out. All right, first up, the big one, opioids. So when you see a patient with that scary respiratory depression, like our patient taking only 8 breaths a minute, and you see those classic tiny pinpoint pupils, your brain needs to have an alarm bell going off that just screams opioids. And what's the antidote? You got it, naloxone. Think of this as your hero drug. It basically rushes in, kicks the opioids off of those mu receptors in the brain, and just completely blocks their effects. It's like flipping a switch to wake the patient up. Okay, now listen up, because this is the biggest NCLEX trop with naloxone. Ready? It wears off. Seriously, it only lasts for about 60 to 90 minutes. But the opioid your patient took, that could last for hours. So what does that mean for you? It means your number one priority after you give that naloxone is to watch them like a hawk. You have to keep monitoring for that respiratory depression to come back. Okay, on to our second key pair. Benzodiazepines, your PAMs and LAMs. Think diazepam, lorazepam. The signs of an overdose are pretty similar to opioids, actually. You'll see sedation, drowsiness, and, respiratory depression. And this gets especially dangerous when it's given IV. So for a benzo overdose, your go-to reversal agent is flumazenil. Seriously, take a good look at this vial. Burn this image into your brain. When you hear IV diazepam emergency, this is the antidote you should be picturing. As the nurse, your priority is all about anticipating this kind of thing. If you're the one giving IV diazepam, you should already know where the flumazenil is. Have it ready just in case. And after you give it, keep a super close eye on their vitals. And don't forget, they are going to be groggy and drowsy, so fall risk is a huge, huge concern. All right, our third pair is a real sneaky one, acetaminophen. And what makes it so incredibly dangerous is that in the beginning, the patient might not have any symptoms at all. They might feel totally fine. But behind the scenes, silently, these toxic byproducts are just building up and absolutely wrecking their liver. And that brings us to the antidote, acetylcysteine. Its whole job is to protect the liver from all that damage. Now, here's a great little memory trick for you, and it's a bit gross, but it works. You'll often hear that this stuff has a really strong rotten egg smell. Kind of hard to forget that, right? Okay, here's a critical number you need to tattoo on your brain for the NCLEX. The absolute max safe dose of acetaminophen in one day is 4 grams. Anything over that, and the risk for liver toxicity just skyrockets. And you have to be on the lookout for this because people do it all the time by accident. Taking their Tylenol and then also taking a cold medicine that has acetaminophen in it. So we've covered the big antidotes, which is great. But what happens when there isn't a simple reversal agent? Well, that's when the NCLX tests a different skill. Your ability to recognize a toxicity pattern and know what to do even when you don't have that magic bullet to fix it. Just take a look at these symptoms. We've got nervousness, tremors, a heart that's just racing, sweating. They can't stand the heat. What's the first thing that pops into your head? Probably hyperthyroidism, right? And you'd be right.
But it could also be a patient who has taken way too much of their thyroid medication, levothyroxine.
And that right there is the trap. The NCLEX loves to test this kind of pattern recognition. The signs and symptoms of a levothyroxine overdose are exactly the same as thyrotoxicosis, a thyroid storm. And guess what? There's no antidote. Your job here isn't to give a reversal agent, it's to recognize the signs, monitor them like crazy, and report it immediately.
Okay, that's a lot of information, I know. So how do you actually make sure it sticks for test day? Let's talk memory hacks. Because trust me, when you're under pressure, mnemonics and those visual anchors we've been talking about, they're going to be your best friends.
Let's just use a classic example to show you how powerful these can be, even for stuff beyond antidotes. For the main signs of Parkinson's disease, just think TRAP. That's T for tremor, R for rigidity, A for akinesia, and P for postural instability. See? Easy. Using simple tricks like this across all your studying can seriously save you on the exam.
Okay, you've got the toolkit. Your brain is primed. Now let's do a quick rapid-fire review. It's time to see if you can break the code when the pressure's on. You ready for this? Let's go. Okay, here's your scenario. Patient's getting IV diazepam. Suddenly they're unresponsive. Their respiratory rate has dropped to 10. What's your priority? Go. What are you doing? It's a benzo, right? So you better be thinking, get the flumazenil now. Let's lock in these patterns. You see pinpoint pupils, you think opioids, you give naloxone. Patient is hot, sweaty, with a racing heart, think levothyroid overdose. Your priority is to monitor. Patient admits to taking a bunch of different cold meds, you think acetaminophen, you give acetylcysteine. Boom, boom, boom.
See? You've got the keys now. You've cracked the code on some of the most important antidotes in pharmacology. So I'm going to leave you with this question. After everything we've talked about, what's the one toxicity symptom that is now burned into your brain, the one you'll never, ever forget to look for? Really think about it, because that's exactly how you make this knowledge stick for good.